at 2 a.m. when he came, isn't it? Yeah. And he was complaining of a lot of sweating, isn't it? A lot of sweating followed by giddiness and
This contains swallowing.
yeah.
Contains swallowing to solid later than
Yeah, so sweating, giddiness, difficulty in swallowing, solid foods, hiccups, and anything else, and giddiness, isn't it?
he was unable to stand
And he was unable to stand because
trying to
he was losing balance. So, in a system one approach, if we see a sudden onset of these cranial nerve symptoms along with motor weakness. So cranial nerve symptoms here are the giddiness is most probably because of the brainstem vestibulocochlear nuclei. The difficulty in swallowing is because of the 9th, 10th, 11th nerve, which are coming out of the middle oblongata. And if there is a middle oblongata involvement anatomically, we call it the medullary syndrome. It can be a lateral medullary syndrome or a medial medullary syndrome. And looks like, and that is because of a vasculature which has been probably blocked. Now, that is our first impression. Anything sudden neurological finding could be a vascular phenomena, and he has the age, he has these vascular risk factors in the form that he is a diabetic for 4 years. He is how old? 49. 45-year old, and he regularly consumes alcohol, isn't it? A lot of alcohol. So we know that vasculatures, the endothelium can be damaged by alcohol as well as visceral fat, and he has smoking also. So given these risk factors, we think that it's most likely a vascular phenomenon. The other possibility, differential, is that it could be a demyelinating illness. So the neurons which are around in this area could also be inflamed, essentially attacked by our immune system, and that inflammation can set off a demyelination which can transiently block all their functioning. So either of these two are possibilities. We'll put our money on vascular, and let us see the way he is walking. Can you ask him to walk a little bit? So he's much better than what he was when he came to us 2 3 days back. Can you కొద్దిగా నడవండి? So you can see here it is much more clearer. That man was also probably having a little bit of ataxia, the previous patient. Here this man's ataxia is phenomenal in comparison to his because he's having much severe ataxia. Like even if you see him anywhere, you'll be able to make out that he's got a neurological problem. So yeah, now he can turn. See how he turns. So see how he's turning. So he's got a lot of problems, and it's all because of the involvement. Now the previous patient's involvement of ataxia was because of the spinal cord area which are called as posterior columns. And this patient's ataxia is possibly because of the brainstem where the cerebellar tracts are moving. So because of involvement of the cerebellar tracts is what we are seeing this severe ataxia. And in that man, it was more of a sensory ataxia where he was not able to appreciate the ground below his feet. He was probably feeling as if he is walking on cotton wool. And that is the reason he was having a milder ataxia. And we confirmed that by making him stand with his legs closed and asking him to close his eyes. And he was faltering and he was nearly falling down. So that is called Romberg's sign. So in that previous person with a spinal cord problem, involvement of posterior columns, lateral spinothalamic tract and pyramidal tract, he had a Romberg sign positivity and he had a mild ataxia. This man with a brainstem lesion, possibly because of a posterior circulation blockage, sudden onset, has got a severe ataxia. And and of course, the therapeutic decisions here are relatively easier. If he had come on time, we may have been able to thrombolyze him or tackle the vessels. But most of the times, we see these patients 1 or 2 days later. And there we just resort to secondary prophylaxis by giving antiplatelets, statins, and essentially we train them to get back on their feet and giving all the mental and physical support that is necessary. So that part is simple kind of therapy. So let's move to the next bit.